Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a cataracta nigra, a black cataract. Let us observe management of this case. The main incision is placed at the posterior aspect of the limbus at around 11 o'clock. This is phenocane. The patient is under topical anesthesia. And now I am going to stain the anterior capsule with trypan blue dye. In this hard and mature cataract, it is not possible to get a red glow. So the anterior capsule has to be stained with trypan blue dye. This is adrenaline. The pupil is mid-dilated, about 6 millimeter, and if the pupil shuts down, if the pupil size becomes small during emulsification of the pieces, we have to use pupil expansion device intraoperatively. At this time, I am proceeding with a Phaco without using pupil expansion device. This is a side port on the left side of the main wound, about 3 clock hours away. And now capsulorhexis. Since the cataract is very hard, I am going to do a large rhexis. For that, the rhexis goes little beyond the margin of the pupil. Yes, adequate sized rhexis has been done. Now hydrodissection is done with BSS and a 27 gauge cannula. Small amount of BSS is injected at multiple points. The nucleus is tapped and the nucleus is rotated. Viscoelastic substance injected again. In such cases, you can use chondroitin sulfate and sodium hyaluronate combination, and beneath that, you can use SPMC. But in this case, I am going to manage only with SPMC. And now, the submarine chop technique. Some superficial cortical lens matter is removed, and the tip is buried in the substance of the nucleus. Now the tip goes through the nucleus, reaches almost near the opposite equator, and a nice crack is obtained. The nucleus is rotated 30 degree to 45 degree and another chop is achieved. And now another 30 to 45 degree on more chop, and this initial crack is goes from one side to the other side. So each heminucleus is being divided into 3 pieces. Every time the tip of the phaco needle goes into the substance of the nucleus, a very firm grip is obtained, and then the chop is carried out. And now each nuclear fragment is being emulsified. The setting is ultrasonic energy 85%, flow rate 48 ml per minute, vacuum is 480 millimeter of mercury, and the Phacomachine is Oertli Catarex 3. The microscope is OMS 800 from Topcon. So we are slowly and gradually managing the nucleus. See the phaco needle. It is moving from side to side all the time. It is not at on point, and the ultrasonic energy is delivered intermittently. So wound burn is prevented in this way. And this is the last nuclear fragment. then the epinuclear shell, and now this cortex, some portion of the cortex is being emulsified by the handpiece itself. Now some nuclear piece which was stuck in the side port was removed. Now the plan is to remove rest of the viscoelastic, rest of the cortical matter with this Simcoe cannula. This is a 23G Simcoe. Once the antechamber is filled up with visco, we get some time. The antechamber is nicely maintained, and we get some time to remove the cortex. And if we lift the anterior wall of the main wound gently, the maintenance of the anterior chamber is very nice. Now I go through the side port and remove the cortex from the sub-incisional area. So cortical cleanup is done. Little bit of cortex may be there at this time, but it is not. Some cortex is attached to the posterior capsule here. We will remove that after implanting the intraocular lens. Now the antechamber is again filled up with 2% HPMC, and the main wound is being enlarged a little bit, maybe 0.1 millimeter or 0.2 millimeter, so that the cartridge engages in the main wound nicely, the B cartridge engages nicely, and the lens can be nicely delivered in the anterior, in the capsular bag. This is a hydrophilic acrylic single piece monofocal intraocular lens, and the lens has gone into the capsular bag. This is an eye hook. We're going to see if the lens is in the bag. Cannot see the rhexis margin, so I use the eye hook to see the rhexis margin and ensure that the intraocular lens is in the capsular bag. And now we have to remove the viscoelastic substance that we have used for implantation of the intraocular lens thoroughly. Initial step. This is removal of some amount of visco with the Simcoe cannula. Initially we irrigate, and after few seconds we start aspirating. And now this is bimanual irrigation aspiration. At this time, all the viscoelastic substance that is remaining will be removed. This is polishing of the posterior capsule, and whatever cortical matter was sticking to the posterior capsule comes out at this time. Nicely done. This is a totally unedited surgery, and you have not missed anything, not a single step. So it is possible to manage such a hard cataract under drop, that means under topical anesthesia, and within 10 minutes. We just have to improve our skills. We have to develop our intuition. We have to foresee the complications, and we have to train our muscles, nerves, and be a very good surgeon, so that we can serve our patients with not only compassion but also with great surgical skills.